activities relating to the detection, assessment, understanding, and prevention of any adverse drug reaction. So as healthcare professionals, when you are giving any medication or your vaccines, what do you have to look out for? And then that is what we call pharmacovigilance. And we have two types. We have adverse drug reaction and the adverse events following immunization. When we talk about adverse drug reaction, it simply has to do with drugs. But when we talk about AEFI or adverse events following immunization, we are, as the name depicts, immunization. So when you give your vaccines, either COVID vaccine or your pen test, and then there is any reaction after, you are supposed to report it to the Food and Drugs Authority. And we are saying adverse drug reaction is any response to a medicinal product. So as you take the medicine, when there is any reaction, you are supposed to report. And it can occur as a result, when you give them, it can be within the terms of marketing authorization. Let's say the manufacturer says PMO is giving 1 gram TDS, and you give it just that, and there is any reaction, you are supposed to report, because it happened after the medication. It can also occur when the drug was abused or overdosed. You don't say, because you didn't take it within the terms of the marketing authorization, you are not going to report. You are supposed to report them. And then occupational exposures. When you are administering any medication and you have any adverse reaction, you are supposed to report them as well. And when we talk about AEF, as I've said, this all has to do with vaccines. So it's also the same reaction after vaccination. And then per criteria, standard criteria, we have serious and non-serious adverse drug reaction or adverse events following immunization. When any adverse drug reaction or AEFI results in death, life-threatening, congenital malformation, hospitalization, or disability, we termed it as serious adverse drug reaction. Hence, when you see the adverse drug reaction booklet, you see the various criteria. So depending on what resulted after the adverse drug reaction, you take whether serious or non-serious. And when we talk about non-serious, it has to do with the intensity of the reaction, which which had not led to any of the 5 that I mentioned above. So how the history of pharmacovigilance? We are saying the history started when this particular product, was given to pregnant women during the 1960s. It was resolving their morning sickness. But then one doctor realized that all the pregnant women who took this particular product were having congenital malformation. So he started gathering data on this particular product. That's how pharmacovigilance began in 1960. So this is the condition that they were experiencing. Testing on fetus before medication is given. So that's when they introduced that particular section into their FDA drug regulation. Then UK started its yellow card system. When you see the BNF, there is this yellow card at the back. It simply means when you have any reaction, you check in the BNF and it's not included as either adverse drug reaction, either side effect or anything, then you have to fill it and submit it. That's how UK started. Then it went global in 1968, and Ghana joined the global in 2001. So Ghana, we've been practicing pharmacovigilance almost 24 years now. So the reason, or why do we have to study pharmacovigilance? We are saying there is no enough data during clinical, either pre or clinical trials. Hence, when the product is in the market, we need to follow up on the product to pick up any reaction or any emerging reaction that is not known with the drug. We are saying that some of the limitations the products during trials, the number is limited. Certain people are excluded in the trial. Hence, when this product comes to the market, the same people consume it. Let's say if you are testing on anti-diabetic medication, people who are diabetic are the only people recruited or included in the studies. But then after the product is on the market, as healthcare, we know diabetes and hypertension are like sisters and brothers. So once you have the other, you definitely may have the other. But then in the trials, there was nothing like that. So when it comes to the market, we are able to pick up drug-drug interactions. That's why we are supposed to report on any adverse drug reaction. And then second is to prevent patient safety in developing countries. Because when you know, somebody will say, how do we come about NSAID with bleeding GIT, or GCSPD with NSAID medication? It all came about as because of pharmacovigilance, because somebody reported and then they picked it up. So maybe you don't know, you can change the face of medicine by just one report that you would have reported. It could be that it's not known with our product, but then after maybe safety and all that, it can be added to the profile of the medication. So we are saying, what can you report on? Everything that FDA regulates, you can report on it, from drug and drug products, herbal products, cosmetics, vaccines, household chemicals, everything. Because even if you say you won't eat, you will bath. If you say you won't bath, you clean your room. So all these are products that you are supposed to report on after your reactions. And then you are supposed to report on lack of efficacy. You are given a certain product and then the patient is not being relieved of whatever is happening. Assuming you give a Coartem, and then anytime you go and check, there is still a plus or 2 pluses. You are supposed to report them. If you are given your antibiotics and still temperature is still going up, when you know you have done everything, just suspect it and then report it to FDA. You just had a sample of the product and then we'll take it to the lab. It could be it's just powder that is on the market. You can also report on suspected defects when you know this ampoule is opened or they've not filed it properly, because whatever they submit to FDA, these are some of the things that they are supposed to do. So if you don't do it and clients are suffering, you need to do the needful. You can also report on medication error. Recently, we had a report from one of the biggest facilities in Accra, Entoregeminal. We all know it's oral product, but if you look at it, it looks like albuterol or water for injection. So somebody injected it instead of oral. And throughout the time that the man was on admission, every day they have to run test upon test just to make sure there is no any reaction. And it's going to be a cost to the clients, because they won't tell you that, oh, it's because maybe we did the mistake or something. Yes, and then suspected counterfeits, you are also supposed to report them. Substandard as well, you are supposed to report them. Then we have timelines for reporting. When it has to do with a serious adverse drug reaction or adverse event following immunization, we prefer the report should be submitted within 7 working days so that we can work on it promptly. But then when it is non-serious, it can be reported within 28 days. This is just ideal timelines, but you don't wait till the 7th day or 28th day before you report. Just when you have any reaction in the ward, you can just report. I know most facilities have ICPs who are like contact persons for pharmacovigilance. So you can contact them and then they will submit the report to FDA. Then with AEFI, we assume it should be reported within 24 hours because we say vaccines are given to healthy population. And if there is any reaction, it's going to cause havoc, so we need to report. Then we have tools of reporting. We have the blue form, we have the Med Safety app, and then we have online reporting, which is Safety Watch system. So you can report using all these various reporting forms. And there are some benefits for reporting adverse drug reaction. You can create a watch list for yourself so that when there is any safety update from FD or international society, you can benefit from it. So in summary, we are saying that safety knowledge is not one-off process. It accrues throughout the life cycle of the product. As long as the product is on the market, you don't know who will be reacting to it. I know recently there is something that has to do with paracetamol that has some. Meanwhile, we know that paracetamol has been in the system for God knows how many years, but people are reacting to it. And the reporting adverse drug reaction is just a professional responsibility. Nobody is paid for it, but then because of the safety of your patient, you have to report on adverse drug or adverse event following immunization. Thank you.
Thank you very much. Do we have some questions for her? Come. Maybe we have one or two questions or some clarifications we need from her. May I know if we have anything to ask? She's telling us about pharmacovigilance, how we need to be careful and mindful of medications, and then the adverse drug effects and all that. Yes. So yes.
Okay, thank you. Mine will not be a direct question, but probably a way to enhance this thing because of an experience that I had. If the electronic report can be enhanced to the extent that with a click of a button, you can do so, it will help. I'm saying so because I had a chance of using a medication and my patient were reacting to it. I had to fill the form. After filling the form, will you be surprised that the supplier had to come to me to impress upon me not to talk about it? Will you be surprised? So it went to even the region. I was called there and I have to explain myself to them because of what I was observing on the medication. Later on, my other colleagues also came in and they realized that they have to pull the drug from the system. So for me, and a junior colleague is there, it means there will be no report. So my plea with the Food and Drug Authority is that let's use the electronic means very well, because that will remove some of these things and encourage people to report. Thank you.
Thank you for the question. With the Med Safety app, it's very easy to use. You can have it on your phone and then use it to feel the reaction that was experienced. So I know there is this product that somebody had a reaction with. Then later they have to call in the manufacturer to come and pick it. So when we were doing a follow-up, they were like, they don't have sample for the product. And so, because usually when there is any production defect, therapeutic failure, we go for samples. By the time you get to the facility, they will tell you they don't have enough sample for the testing. So once we receive the information early, we are able to come for the sample and then we do the needful. Thank you. So the online Med Safety is very easy to use. Thank you.
Okay, thank you. Good evening. Please, I just want to know what relationship you have with antimicrobial stewardship program. Antimicrobial stewardship. There is this group in our facilities who are interested in the use of antimicrobial products and how it is used and whatever reaction. I mean, it's a whole small system that is run in our facilities. I don't know how you are related.
So I don't even know about that, but then I'll find out. Because if it is a test they are doing, they will definitely have to write it to FDA, the clinical trial sections, and then they will either give them the permission. But actually, if you are doing anything, you definitely have to involve FDA because of the safety of the product. So if you are doing it maybe on the blind side of FDA, I don't think maybe, personally, I have no knowledge about it, but then I'll find out whether there is something that has been communicated. Thank you.
Please, I want clarifications on the AEFI. You talked about the duration. You talked about 24 hours, 7 days, and 28 days. Can you expatiate on that?
Yeah, so with the adverse drug reaction, we are saying the serious ones can be reported within 7 days, but the non-serious can be reported within 28 days. Adverse drug reaction related to drug product or medicinal product. But with vaccines, that's when you are supposed to report 24 hours when it's serious, because with vaccines, they are given to a large number of people. So if there is any serious reaction to a certain batch, it needs to be brought to the attention and then either be called off or halt that vaccination. And it's given to healthy people. But when it comes to medicine, you are already sick and then you went for the medication and you had reaction. So it might not even come to your attention that it's a product. But once you take the vaccine, you know that when I was growing, I was healthy until I took the vaccine. That's why it's supposed to be reported within the 24 hours after vaccination. Thank you.
Thank you very much. My concern is about traditional medicine producers. What are you doing? Because when you take one medication, it's treating God knows number of diseases, and because it's categorized as traditional medicine, most people react, but they find it difficult to report because now they're everywhere, you know, and they will say this product is approved by FDA, fine.
Thank you. And I know it's not all the products, medications on the market that are approved by FDA. And when it comes to products or traditional medicines, we are trying to lobby them to come under one umbrella so that when it comes to dosing, the healthy under which they will produce the product. Because it's been with us for a very long time. So we are trying to just pamper them so that they will come under one umbrella. But then the ones that are approved by FDA, you can check with us, and when there is any reaction, FDA takes it up. Sometimes someone can react to this particular product. When you call the reporter that, oh, you reported on this product, can you show us where you bought it? They will tell you that they can't snitch on the person. So sometimes we find it very difficult even to trace where these concoctions. And then sometimes they are in gallons. How can you even take this product? And we had an incident that the patient is retro positive, and her husband told her to stop taking the antiretroviral medication, then consult to the tradition. She died, and then when they were sending us the sample, it was in a Voltic bottle, small bottle, and we're like, if they show us where they bought it for. The man said he has been following the ICP, or the reporter said we've been following the husband and he has refused to show them. So sometimes it's our people, if we follow up on them and they show us, we do market surveillance that we can go, not just to sack them out of business, but just to bring them under one umbrella, because we usually have trainings for pharmaceutical companies, so we do for herbal products as well, so that they can do the proper dosing and any other, because when they are submitting the product, we do microbiology studies so that we can rule out any microbiology that may harm individuals. And then the actual ones that are registered, you never see them listing a lot of indication for use. It's those that have one-man shop and they are herbal concoction that will be telling you it can cure so many conditions. Thank you.
So mine is on adverts of drugs. And then, so I know a popular one around Hacho. And this person sells drugs. And the person says that in the adverts, I think it's recorded, so it's always playing. That's Babaso, which the white man called gonorrhea. Our French, a French friend is syphilis. And this is every day when I'm passing by, I say, so no member of FDA passes here. So this is a wrong advert, 2 different causative organisms. And the same medication, babaso, in Chi, gonorrhea in English, French, and syphilis. And it's recorded. So anytime you pass around the Hacho station, it is there. And he will tell you gonorrhea is not only from sex, but also from indomie and oily foods. So I wonder, in fact, they play it every evening. So I don't know if I can also report this to FDA because it's serious.
Thank you. Actually, when it comes to this public advertisement and anything, it's under national communication. So it's not under the jurisdiction of FDA, but usually we work with the National Communication Authority. So once we get such reports, then FDA will work with National Communication, then Municipal Assembly, because I know it is the Municipal Assembly and the District Assembly that has allowed them to use the information service. The information services are under Ministry of Communication. So when it comes to our attention, then FDA can work with them to do it. Because I remember there was a market surveillance that they have to talk to the District Assembly to stop those things. But they will tell you that this is how they also get their monies, and it's under national communication. Yes. Because if you're advertising your products under the community information service, definitely they will take something from you. They won't let you advertise for free. So we'll take it up. You said Hacho. Please, which part of Hacho? The taxi rank. Going to, oh, I live around Atomic Down Kwabenya, so if, Hacho, thank you.
All right, so mine is, you said it is not only about what we take in, but what we even use on our skin and what we use to clean. My issue is to do with cosmetics. Now there are lots of cosmetics around that are causing adverse effects. So how do you work around those ones? For instance, a product like cocoa butter. You see it from different producers, from different, made in China, made in the same products. And sometimes we don't even know which ones are good for us and which ones we are reacting to. So what do you do about those ones?
Okay, thank you. When I was presenting, I said suspected. So yours is just suspect and then submit it with a sample. You can even be a picture and then the badge number of the product. We know our borders are very porous, so infiltration of certain products is very easy. But once you submit it to FDA, we do market surveillance, and then we can call you and ask you where you purchased it. We can just go pretend we are buying the same product from the market, and then we can pick it. There is this Coke in town, the one that has names and all that. It expired last Tuesday, 30th September. So please, if you are buying Coke, look at the expiring date. I sent it to my boss. I called the lady to ask her where she bought it from. She'll be like, tomorrow I'll call you, today I'll call you. Just send me just the distributor's name. She's telling me she'll call tomorrow to come. It's best before. But we know anything that is best for before, you might not get the healthy benefit of whatever you are consuming. And they have produced and said, this Coke will expire 30th September. That's last Tuesday. So if you buy any Coke product, especially with the Coca-Cola, please look at the expiring date. Thank you.
Yeah, thank you very much for your good presentation. I want to find out, I don't know if it is within your jurisdiction. Most of the drugs we do experience side effects sometimes are adulterated. And I don't know how they often get into the system. And severally we have seen Food and Drug Board calling back certain products. How they got into the system, I don't know how it happened. Whether you work with the borders or those who are responsible for allowing products in or not. How can we do to curb it? Thank you.
Thank you. I earlier said our borders are porous. So infiltration of certain products is very easy. When you go to Togo, the border between Ghana and Togo, not the main Aflao border, but just corners. It's just a branch of leaves that separates Ghana from Togo. And you can meet somebody that's having a conversation with a colleague in Togo. So our borders are very porous, but usually we work with the intelligence department, the security. Currently, we've had some seconded security officers that when we're going out, we go with them. And we have regional officers who also go for operations with the immigration officers and there's other security officers. So once we get in touch with the product, we collect them and then destroy them. So it is nationwide. FDA staff are like 1,000 and a little about 1,005. We know we can't do it all. That's why we employ healthcare professionals, because you are the first call when a patient comes to the hospital. So when you become our eyes and ears, you help us do the right thing in the nation. Thank you.
Thank you. Hello. Okay, so my question is in relation to your observing of sale of medicine on social media, especially Snapchat. I don't know if FDA has taken notice of this, but if you go to Snapchat, the medicines that are being sold, it's something else. So I wanted to find out, do you have a division that is in charge of this, or there's none? So the business is still going on Snapchat. Thank you.
We have officers who are in charge of social media and things. Sometimes they might not, I don't know how, sometimes they get to have the hint that FDA is coming around. I remember there's this woman, Mama G, that was at Medina. She was selling this product that we picked it up and you have to pay huge fine. Usually we don't want to imprison people because prison does not reform people. So we just put a hefty price on you. But if you're able to pay, sometimes it's difficult for them to pay. So then they are out of business. So when it comes to social media, as I said, it's under the Ministry of Communication. So we work with them. When it comes to our attention, we cannot just go and make the arrest. So we have to work with the National Communication Authority. And you know how Ghana, our system is. Sometimes they will tell you we don't have the resources to go here and there or that. But then we work with the National Communication Authority. Thank you.
Okay, so please, in relation to the Hacho incident, you said you liaise with the Assembly and other agencies to regulate and get these people. But here lies the case, in the case of Hacho, I reside there so I know. The person is not having a shop or a store where the person is operating. The person is operating from the back of a van. You understand? With a megaphone. And that thing is now being consistent in many areas where they use megaphone and behind of cars to sell these drugs and all that and misinform people about the purposes of the drugs and all that. So how are you going to regulate all that, or what are the measures in place? Because it's really getting to the market.
These people, we don't really regulate them because they are individual people. So what we can do is that, as you brought it to our attention, when I go back to the office on tomorrow, we have to communicate with our communication department that this is what people are reporting around Hachu, so that we know we can take it up from there. Thank you.
Right, let's give it up for her. Thank you so much. Memuna, where are you? Thank you. Yeah. Just give us a wave. Where's Memuna? Okay. Right. So we'll just zoom into the next session. Another interesting one. And fortunately, we have our chairman already up here. So our chairman for the session, the one who moderates for us, is Dr. Mrs. Abigail Agatha Che, immediate past president of the Ghana College of Nurses and Midwives. She has a rich experience in managing large-scale health programs. I know for Danida, for Jipaigo, the way she raised her eyes. And she has worked all round the world. I know she had to go to Malawi, and then she was doing a lot of pre-service education she's one of those who actually made Jipaigo what it is in Ghana, and they've supported a lot of institutions, especially the training institutions. And Dr. Che, her name is Ghanaian by birth. She is very devoted and committed to rendering her services in the cause of women and children in developing countries, more especially in Africa, including her home country, Ghana. Dr. Che was the chief of party for Jipaigo Access for about 7 years, I think. Then she also was under the International Confederation of Midwives. She was an international midwife advisor. She worked on joint UNFPA ICM programs, a lot more. She's been to Africa, Asia, Latin America. I told you she's an international woman. So this one is a small job for her. And as we come together now for her to chair this program for us, I would wish that we give her a standing ovation. Dr. Abigail Agatha Che, IPP, immediate past president of the Ghana College of Nurses and Midwives. If I have to read her profile, we may finish tomorrow. Thank you very much. Thank you. Sit.
Good evening. Hey, please. Good evening. Me, I want the response. It's very important. The one she didn't add is that I'm a grandmother too. That one, I never leave it out so that when I take my seat, you'll understand. And you not let me stand there for a very long time. Thank you very much. We are very grateful to God for another opportunity for us to have a scientific session. And we learn a lot from it. I'm so sad that the rain has stopped people from coming here. But if they were working in the US or in the UK, they would still come, even if it was snowing. But those of us who are here, we are fortunate. So as we know, our main theme is enhancing specialist nursing and midwifery practice, a call for investment, collaboration, and innovation. And to do justice to the theme, we have seasoned presenters who will be taking them under the various sub-themes. So our first presenter, Mr. Albert Opoku, has the topic, Nursing and Midwifery Students' Perceptions of Sign Language Training in Ghana, Relevance, Instructional Methods, and Assessment Practices, under the sub-theme, Interprofessional Collaboration and Education. Mr. Opoku, who is mounting the platform, is a fellow of Ghana College of Nurses and Midwives and a registered nurse holding an MPhil in Physiology from KNUST, Kwame Nkrumah University of Science and Technology. He graduated with first degree in nursing with psychology from the University of Ghana, Legon. He also acquired a certificate in minimally invasive surgical techniques from Shandong Province Foreign Trade Vocational College. In where? What's the name of the place? Qingdao. I didn't want any problem. Qingdao. Because the spelling starts with Q and I'm supposed to say Ch. So in Qingdao, he was the principal at Nursing and Midwifery Training College, Tepa, and currently the principal Nursing and Midwifery Training College, Sampa, in the Brunei region. So, Mr. Opoku, you have 12 minutes. Please, don't disappoint me by adding more time to you.
Okay. All right. Thank you, Madam Chair. Good evening, President, Rector, and all other members around. This evening, I'm presenting on nursing and midwifery student perception of sign language training in Ghana, relevance, instructional methods, and assessment practices. Now, the Outline will go like introduction, research, objective, methodology, results and discussion, conclusion, and then a recommendation and references. Now, according to WHO, persons with disability is about 1.3 billion in the world, and out of that, about 5% are having issue with hearing impairment. In Ghana, about 1.7% is estimated to have hearing impairment. Now, nurses play a very vital role in taking care of all patients, including the deaf patients. Now, in 2016, something happened in Ghana where a deaf patient died, and the Ghana Association of Deaf came out strongly on the media that their member died because of language barrier between the health professionals and their member. As a result, the registrar pronounced that we are going to introduce sign language, and subsequently it was introduced into our curriculum. Now, with this introduction, there has been an argument for that and then against. Those for it says that it is important because it's going to enhance care of the deaf patients. And then there are other critics who also say that even in the developed countries where they are much concerned about the disabled, they don't introduce sign language in their various institutions. Others also believe that our curriculum is already packed, and therefore bringing it or adding it to the curriculum is going to increase the number of hours for students, putting more pressure on our students. So this study was set with the objective of examining the perceived relevance, teaching methods, and then assessment practices of the sign language training in Ghana. So we are looking at the relevance from the student point of view, the teaching methods from the student point of view, and then the assessment practices. Now, the methodology that was used was a cross-sectional survey with a quantitative approach. The targeted population, the final year nursing and midwifery students from the various nursing colleges, and then the second years. Now, this is final year students. So for the NAC, they are second year students, and then for the diploma, third year students, because they might have done the course. And we did the survey between 2 months, 15th May to 15th July in 2024, with a sample size of 468 using the Cochrane's formula to estimate the sample size. And then with the data collection tool, standard questionnaire was set based on the objectives, the relevance, the teaching methods, and then the practice. And then we had about 40 questions in the questionnaire under 5 sections. Data was analyzed with the IBM SPSS software 2004 version. And then data was presented with the descriptive statistics, the percentages, mean, and then standard deviation. Now the results. Let me go straight to the main results. Now the results show that students recognize that sign language is very important, and therefore we need to continue it. That was their version of it. So students recognize the importance of sign language in training, in providing care for the deaf patient. So the score, the mean was 3.8, standard deviation 1.067. And then promoting diversity in healthcare. The students were with the view that sign language will provide diversity in healthcare, help with the student taking care of patient with death. And then when you come to confidence in applying the skill, that is where there was a problem because of lack of practice. Because getting an encounter with the deaf patient was a problem because there are not many in the system. So the practical aspect was a problem. So that the standard deviation was 1.207 there. And then students appreciated the engaging instructional method. So the teaching method, they appreciated the teaching method. Now when it comes to the validity of the assessments, students were very happy with it. Now the reason was that it is non-scoring. We don't score them for their final exams. And because of that, they were very happy with the assessment process or procedure. But the emphasis, as I've already said, has to do with the practical training. So the results is showing that there's limited practical training, feedback from the tutors to them, and then the skill that they can use for the interpretation. Now, with the discussion, we have already talked about the fact that the study finding was students have had it that there's relevancy of the course in taking care of deaf patients. Now, this was supported with a research study by Kobeck et al. 2016 and then Impra et al. 2013. And then the teaching methods, as I've already said, students appreciated that the teaching method was very good, and this has also been supported with the literature, and the literature also supported it, and then also recommended other method of teaching in addition. And then the last aspect has to do with the fact that students appreciate the assessment, as I've already said. Because it was non-scoring, they liked the course very well, and therefore the assessment procedure, they were very interested in that. So here the literature is suggesting other method of assessment like video-based assessment, simulated patient encounters, and then continuous assessment. Now the study concluded that the value of sign language training is relevant, but the gaps in it has to do with the practical application and then the confidence of the student to be able to practice it to take care of the patient. And then the recommendation from the study, NMC and then the nursing and midwifery colleges should increase practical training opportunities, standardized assessment, and then feedback mechanism. And another recommendation to the Ministry of Health and the Ghana Health Service is that we may have to train professional interpreters in our hospitals instead of maybe trying to force it on every nurse in this country, because I've searched the literature. I've not seen any country that their curriculum is saying that all the health professionals or the nurses should learn the sign language to be able to take care of the deaf patient. Okay, avenue for research. If we have to actually continue with this program, then we have to do more research, longitudinal one, to find out whether students can be traced from school to the clinical sites to see whether they will be able to actually learn the language and then interact with the deaf patients. And then there's also the need to find out from the deaf patient whether when they come to the hospital, the nurses are able to communicate with them with their language. So that is the avenue for further research. So in our next research, maybe we may take it up, or others can also take it up. All right, so these are our references, and then this is my details there, and then the link for the research. It was published in the BMC Nelson, so that's the link. If you want to get more information, there are a lot of interesting literature in the reports, so that people can read about it. So thank you for listening. I think I'm able to deal.
Yeah, within time. Thank you very much. The other presenters, please emulate Mr. Opoku. He has done very well. He kept to his time. The second presenter is Miss Grace Arthur, and her topic is disaster preparedness among emergency nurses at the GAM North Municipal Hospital, under the sub-theme investing in nursing and midwifery specialization. Grace is a senior nursing officer at GAM North Municipal Hospital and an emergency nurse resident at the Ghana College of Nurses and Midwives. She holds a BSc and diploma in nursing with over 15 years of clinical experience. Her expertise spans emergency and outpatient care with research interest in healthcare systems preparedness. She is particularly focused on strengthening resilience and disaster readiness among healthcare professionals. It looks like her boss is coming to present for her. I don't have her bio, but she will present for the person, Miss Grace. Yeah. And can you explain why she's not here?
She's indisposed. She came, but she was not feeling well.
Oh, okay. So let's give it up for her for coming to do it for her. You have 12 minutes.
Okay. So my name is Dr. Mrs. Cecilia Eliasim. I supervised her, and she's indisposed, but she was here this morning for the induction and graduation. Okay. So her topic was, just as mentioned, disaster preparedness. She tried to evaluate how prepared the emergency nurses were. So it was conducted at Ghana Municipal Hospital. So this is our outline. Next. Okay. In 2019, about 308 natural disasters occurred, affecting almost 97.6 people worldwide, with nearly 97% linked to temperature, weather changes. And we all know that currently climate change, things are changing. And then in the Sahel region, natural disasters impacted nearly 300 million people, distributed as 59.17 in East Africa, 36.48% in West Africa, and 4.35% in Central Africa. And in Ghana, road traffic accident is very common, just like malaria. So this study tried to highlight the urgent need to strengthen emergency nursing capacity in disaster response. The objectives are to evaluate the disaster preparedness among emergency nurses, and the specific objective which were in line with the Donabedian theoretical model, that is the structure, process, and outcome. So we have to assess the structure of disaster preparedness among nurses, including the availability of resources, policies, and protocols for disaster response. And the second one, to evaluate the process of disaster preparedness among nurses, including their knowledge, skills, and attitude towards disaster response. And then for the outcome, to examine the outcome of disaster preparedness among nurses, including the ability to respond effectively to disaster situations. So we use a qualitative study, that is the exploratory descriptive study design, to recruit 13 nurses working at the emergency unit. 11 of them were females and 2 were males. And purposive sampling was used. Data collection was done concurrently with data analysis. It followed Brown and Clark 2022 process of data analysis. Rigor was ensured, and ethics was received from Ghana Health Service Ethics Review Committee. Now, so that's the Donabedian structure that guided the design of the work. So we have the structure that looked at the staff, equipment, and guidelines, supply, and the process looked at the interaction, investigation, examination, treatment, and then counseling that goes on at the emergency. And then the outcome looked at morbidity, mortality, and satisfaction. Now, the key findings. The 3 major themes emerge from the analysis with 10 sub-themes. So we take each of them. So for the structure, what we found was basic supplies available, oxygen, BP apparatus, and basic monitoring tools were available. The gaps, no dedicated ICU, limited diagnostic tools, inadequate staffing, and then absence of disaster-specific protocols at the emergency. Then activation of disaster committee is an ad hoc and reactive. In summary, structural limitations significantly hinder preparedness. Then for the process, shared understanding of disaster concepts, lack of formal disaster training, mostly basic life support only, inconsistent charge application due to staffing shortages, and then weak communication and unclear chain of command. Processes are poorly institutionalized and inconsistently applied. And then for the outcome, positive recovery for stabilized patients, referral delays reduce survival chances, weak referral systems and limited ambulances services, moderately successful preparedness, 60 to 90% effective reported. Outcomes are moderately positive but compromised by system failures. In conclusion, the study concludes that while emergency staff demonstrate commitment and basic competence in handling disasters, their efforts are constrained by inadequate training, under-resourcing, and fragmented coordination. And for recommendation, we recommend that implement structured disaster preparedness training for healthcare staff, strengthen staffing capacity and establish efficient referral systems, promote enhanced interagency collaboration to improve coordinated response, advocate for policy reforms that prioritize disaster readiness in healthcare, and then develop a sustainable framework for continuous monitoring and improvement in disaster response system. These are references that we use. Thank you very much.
Thank you very much. I hope more bosses will come and take over from their students. He has outdone it. Saved us more time. Please write your questions down as they are presenting. And then when it comes to the last point, we will now ask our questions. Thank you very much, Dr. Eliasen. The third presenter is Mrs. Dinah Asantua Cranting, Reverend Mrs. Dinah Asantua Cranting. Her topic is unspoken but felt, psychosocial expectations of adults with hematologic malignancies from healthcare professionals at the Kolebu Teaching Hospital, under the sub-theme, investing in nursing and midwifery specialization. Mrs. Dinah Asantua Cranting is a nurse educator with 19 years of teaching experience and currently a PhD candidate at the University of Ghana, the immediate past faculty chair for hematology and the current vice president of the nursing division at Ghana College of Nurses and Midwives. Her research interest is in blood-related conditions, a grant winner from Banga, Africa, and STTI. She has delivered several seminars and conferences, local and international, with a publication on anemia among older women. Please, let's welcome Reverend Mrs. Cranting.
Thank you very much, Ma'am, and thanks for the opportunity. So I'm presenting on unspoken but felt psychosocial care expectations of adults with hematologic malignancies. And my co-authors are Professor Samuel Ajololo, Dr. Yvonne Nati, and Professor Lillian Akofa Ohene. Please find the outline of my presentation. By way of introduction, evidence shows that 20 million new cases of cancer are diagnosed annually, with 1 in 6 deaths. Hematologic malignancies are blood cancers, and they tend to affect or originate from the blood, lymph nodes, and then bone marrow. The trends now that we see is that there's an alarming increase in the incidence of hematologic malignancies, and this comes with an increase in symptom burden of the disease. Some symptoms that patients with cancer experience are also experienced by those with hematologic malignancies, but then they also have their unique manifestations peculiar to them. For instance, they have anemia, they have bleeding, and they tend to have issues with infection because of compromised immune system. These symptoms, the treatment, and then the unpredictable nature of blood cancers or hematologic cancers tend to cause psychosocial distress among persons who have the condition. The high psychological distress among these patients results in poor health outcomes. The adults who have the hematologic malignancies have a lot of expectations when it comes to the psychosocial aspect of their health from healthcare providers. Unfortunately, they are not able to share them most of the time, and therefore these needs are overlooked. Because they are unmet, they lead to dissatisfaction with care, non-adherence to treatment, and poor quality of life. So the purpose of this study is to explore what adults with hematologic malignancies expect from healthcare professionals regarding psychosocial care. And this is what exists in literature, that psychosocial health is known to be the balance between one's sources of stress and social support. And the psychosocial aspect of cancer care appears to be neglected, especially in low and middle income countries. And patients who have their psychosocial needs met are better able to make decisions and manage their disease conditions, which lead to better health outcomes. So the methods, how did we go about this? We use an exploratory, descriptive, qualitative approach, and then the population is adults who have hematologic malignancies. The setting was the Kolebu Teaching Hospital, hematology, OPD, and then the sample technique was purposive sampling. The size was determined by saturation. So at the end of the day, we had 12 participants to attain saturation. And data was collected using semi-structured interview guide, and it was one-on-one interviews. Data analysis was informed by Brown and Clark thematic analysis. Ethical considerations. So ethics was obtained from the Kolebu Teaching Hospital IRB, and permission was given to get into the department as well. Participants' consent was gained, confidentiality and anonymity assured, voluntary participation was also assured, and then there was support provided by the team or the researchers for participants' psychological support. Knowing the area in which we were exploring, the fear was that some of them may go into distress in an attempt to recollect what they have been through. So there was a psychologist on standby to assist when the need arose. Rigor and trustworthiness ensured through prolonged engagements, peer debriefing, purposive sampling approach, member check-in and data saturation, reflexivity, and audit trail according to the Gruber and Lincoln criteria. So what are the findings? Looking at the participants' demographic characteristics, patients were identified using codes, special codes. So we used KG01 to KG12 to identify the various participants. There were 9 males and 3 females that were who participated in this study, and almost all the participants were Christians with the exception of one who was a Muslim, and 7 of them were married, the remaining 5 were single. Looking at the age distribution, we had 4 belonging to that age range, 25 to 44, 45 to 64 were 6, and then those who were above 65 were just 2. Their level of education was mainly tertiary education, 7 of them, and then secondary, and then primary, just 1. Employment status, majority of the participants were unemployed because of their disease condition. And those who were employed, the 3 out of the 5 that were employed worked in the informal sector, and then 2 worked in the formal sector. And we have various types of hematologic malignancies, so we tried to pick up the type that the patients had. So chronic lymphocytic leukemia, there were 3 patients. Chronic myeloid leukemia, CML, 2. The non-Hodgkin's lymphoma were 5, and then multiple myeloma, we had 2 participants. Now, to the themes and sub-themes. We had 2 major themes, and each of them had 3 sub-themes. So the major themes were therapeutic connection and then professional presence. And under therapeutic connection, the sub-themes that were identified were empathy, respect, and then encouraging support. And then under professionals' presence, we had availability, attentiveness, and timely professional communication. So now I'll take them one after the other and give some of the quotations of the participants. So under therapeutic connection, under the sub-theme empathy, so most patients expect healthcare professionals to demonstrate a genuine understanding of their feelings and experiences. And one of them said, so putting up some smile on their faces, making reference to healthcare professionals, and then making us really know if there is going to be a cure or going to be a time when I'm going to come back for another treatment. So if you are preparing for it, you prepare for it. And then under respect, patients express the need to be respected and treated with dignity by healthcare professionals. So one of them said, talk to me with respect. When people talk to you anyhow because you are sick, it is hurting. And she said this with tears in her eyes. Then encouraging support, patients express their expectation of us giving them support to strengthen that connection. Then theme 2, which talks about professionals' presence. The sub-theme availability, patients indicated that they need to have healthcare professionals present and confidence to provide care in response to their psychosocial needs. So one said, if I come, maybe you can sit down, you ask me, oh, how am I feeling today? Do you have any problems? And then under attentiveness, one said, if you ask the patient, he will tell you more. The doctors will not get time to listen because there are a lot of patients. So the nurses would have to continue doing this. And then professionals' presence, the timely professional communication, which is the last sub-theme. Most patients value updates on disease progression, which reduces their anxiety. So one says, sometimes I expect that having examined the lab reports, they should be able to say something when they share this with you. At least you'll be a little okay. So this study findings corroborate previous studies where it exposes that there is lack of priority when it comes to provision of psychosocial care to patients who have hematologic malignancies. And it also exposes that patients with hematologic malignancies have unmet psychosocial expectations. And patients with hematologic malignancies expect healthcare providers to initiate conversations regarding their psychosocial challenges. In contrast to what we find here, in places like UK, a study identified that patients willingly would share their psychosocial challenges with their healthcare professionals. But then it's also out that patients with hematologic malignancies value psychosocial support and a therapeutic relationship with healthcare professionals. But in Ghana, high workload of healthcare professionals is a major obstacle to psychosocial care when it comes to cancer management. In conclusion, Patients express the need for stronger, more trusting relationship with their healthcare providers. And then improving psychosocial care will foster better treatment adherence, satisfaction with care, and patient outcomes. Recommendations for health training institutions, we're saying that training for nurses and healthcare professionals in relationship building is important. It's also important to invest in specialization programs that include psycho-oncology. For practice, the recommendation is that we ensure psychosocial screening of these individuals and support multidisciplinary approach to their management. And then we are also recommending that policies be strengthened to advocate for psycho-oncology care and also to integrate psychosocial care into routine oncology practice. For research, we are recommending that further research be carried out on psychosocial care integration in Ghana. And I have a few of my references here. I wish to acknowledge my supervisory team, faculty members of the School of Nursing and Midwifery, University of Ghana, patients and staff of Hematology Department, Kolebu Teaching Hospital, Banga Africa for the financial support in this particular study, and then Right to Finish Club, and then PhD cohort 2. Thank you.
As for today, I'm very happy. They are so much on point and on time. Please, let's learn from them. Thank you very much. The fourth presenter is my namesake, Mrs. Abigail Kusiamponsa, DG. Her topic is Bridging Professions and Borders, a South-South interprofessional education initiative to strengthen maternal mental health, under the sub-theme Interprofessional Collaboration and Education. Dr. Mrs. Abigail Kusiamponsa, DG, is a senior lecturer at the Department of Public Health Nursing, School of Nursing and Midwifery at Kwame Nkrumah University of Science and Technology. Her research spans pain management, maternal and child health, palliative care, nursing education, and health system. A foundation fellow of the Ghana College of Nurses and Midwives, and a FEMA fellow. She has over 50 publications and supervised more than 80 research projects. She is passionate about advancing nursing practice and policy through evidence-based research. Let's welcome my namesake, Abigail.
Good evening to us all. And I must say that on behalf of our research team, led by the principal investigator, Professor Victoria Baum, who happens to be our president, I'm very privileged to do this presentation on their behalf, or on our behalf. This is the outline of, the topic is Bridging Professions and Borders, a South-South interprofessional education initiative to strengthen maternal mental health. And this is an outline of our presentation. We did this study basically with the goal of designing, implementing, and evaluating an interprofessional education program focused on adolescent maternal mental health. By way of introduction, adolescent pregnancy remains a significant public health challenge, especially in low and middle income countries, as it is often compounded by significant mental health risks such as perinatal depression, anxiety, stress, among others. And despite the growing awareness of vulnerabilities, we realize that healthcare education in many LMICs remain discipline specific. That is, it's fragmented in that when we are educating doctors, we do it separately. When we are educating nurses, we do it separately. And so there isn't that sort of
collaboration among us, and which invariably means that when we end up in practice, we are also more likely to be practicing in solo without really having that collaborative sort of efforts towards the care that we provided. And so by virtue of that, we had a number of things that we did. And I must say that this is not just one study that we are presenting, it's an entire project that we are sharing where we are at this moment with you. So in starting the project, we had to begin with a systematic review on the factors that influence the perinatal mental health of adolescents. And we realized that till date, there hasn't been any global evidence on the subject. And so we used 4 databases, and having over 50,000 primary studies, we came to 37, out of which we explored the factors. And we realized that some of the factors sort of bordered on personal, some also on social environment of these adolescents. Following on from there, we also did a cross-sectional survey. As I earlier alluded, we did the review to inform us of what was known to guide our steps. And we realized that social support was one of the factors that influence the perinatal mental health of these adolescents. And so with the cross-sectional survey, we also did some pilots with 4 facilities at various levels. So we chose from level B and then level C and even level D. And then we sort of examined their demographics as well as some of their mental well-being, as well as issues with regards to their social interactions with family, friends, and then others. So most importantly, their partners. Following on from this cross-sectional survey, we also put a team together which comprised of experts in obs and gynae, midwifery, public health, mental health, psychology, together with a group of students, and then we also co-developed this intervention. After the development, we pilot tested its feasibility with a group of students both in Ghana and then in Uganda. And so during the educational program, 60 participants, 40 from Ghana and 20 from Uganda participated. And then we also evaluated the pre and post competencies such as their knowledge, attitudes, and their self-efficacy, all of which showed improvements. Following on from there, 6 weeks after the program, we also wanted to assess the medium-term sustainability of the educational program. And so we did another evaluation where we wanted to know how they perceived this education. And this program evaluation was guided by Kirkpatrick's model of program evaluation. And we basically were assessing at the level of learning and also their reaction to the program. We can move on. Yes. So, we were very privileged to be funded by the National Institute of Health, Fogati International Center, through the AfriHealth, which is the African Forum for Research and Education in Health. And as we said, we did a pre and post quasar experimental design using validated tools. And this is where we assess the students' knowledge, attitudes, and collaborative skills. And still following on from our results, our review showed that there are a number of factors, as I earlier mentioned, some operating at a personal level, others also from the external environment of the adolescents, sometimes from stigma, from support, from societal perceptions, even from the attitude of healthcare professionals. And I must say that this review, this particular paper is currently under review, and we are hoping that very soon it will come up, but there were a lot of interesting things in that. Still on the results, we realized that the educational intervention improved the students' skills. It increased their knowledge of mental health, and based on that, they expressed that they were ready to really collaborate among themselves
even when they went into the field of practice. And they also said that it enhanced their teamwork and capabilities. I must also say that the educational program was also delivered by a multidisciplinary group from all the areas that I shared. And the students were also mainly from medicine, nursing, and then midwifery. In conclusion, we want to say that this initiative demonstrates the feasibility and impact of a South-South collaboration in advancing interprofessional training for maternal mental health, and that these findings provide a scalable model for improving adolescent maternal mental health through interprofessional education, research, and cross-border collaboration. Our recommendations are a lot, but this is just a summary of it. Based on what we have done so far, we region of interprofessional education into pre-service education, meaning that as nurses, midwives, all other healthcare professionals are training, we should make sure that we are bringing different professional groups, even at the time that they are not yet licensed, so that they can learn together, collaborate together, so that they are more likely to implement this post-registration. Also, we recommend that there should be the promotion of psychosocial assessments in antenatal care. As you reckon, currently we don't really spend much time on assessing the psychosocial issues that affect pregnant women, more so with adolescents who, as we learned yesterday, that is like a child taking care of a child. And so they have really compounded issues, and we need to take keen cognizance on this. I think that there are also a number of things that we hope to do, and we'll be very happy if you've seen any funding body who would like to do large scale of it, would like to implement the support for the teen mothers and even pregnant adolescents, and also test their feasibility among this group. And there are other stakeholders that we wish to engage beyond the students that we did. We hope that we can even extend this to other professional groups and all. So we will once again, on behalf of the team led by Professor Mrs. Victoria Bam, Dr. Rose Chalo from Uganda, Reverend Sister Professor Frances Emily, Mrs. Alberta Lomote, Dr. Roderick Emil Larson Randolph, Sandra, and then Mr. Hayford Isaac Budu. We are very grateful for your audience, and we look forward to other suggestions on how we can take this forward. Thank you very much.
Please give her, she's called Abigail. I'm Abigail. Clap for her. She's done very well, and she's also cut down on her time. Thank you very much. And the work was done by so many gurus, including our president. So why not? Anyway, the last and fifth presenter is Miss Olivia Nyaku-Mensah. Her topic is qualitative comparative analysis of traditional classroom and clinical-based versus digital enhanced virtual teaching and learning in Ghanaian specialist education, stakeholders' perspective and experiences. This is a very loaded topic. Under the sub-theme, technology enhanced learning in specialist nursing and midwifery practice. Reverend Olivia Nyaku-Mensah, also known as Reverend Mrs. Olivia Eshan, is a lecturer at KNUST, a pediatric and neonatal nurse with work experience spanning over 20 years. She is a foundation fellow of the Ghana College of Nurses and Midwives and fellow by examination with the West African Postgraduate College of Nursing and Midwifery. I don't know how to say their acronym. WAPCNM. I mean, let me spell it. I don't want trouble. She's a consultant and specialist in maternal, newborn, and child reproductive health nursing and educational leadership, curriculum planning, development, implementation, and evaluation, and also has attained other higher credentials and affiliations. Her latest research work dives into Pediacom project, development and validation of an AI-assisted interactive communication tool for pediatric care quality improvement in Ghana, conceptualizing the interactive communication of psychological safety for care quality improvement in African pediatric setting, and developing strategies to create awareness on obstetric fistula for Ghanaian women and girls, evaluation of emergency and critical care practices and competencies of nurses and midwives in maternal, newborn, and child health facilities in Ghana. Outside work, she is passionate to be used as God's instrument of peace. She's good in cooking, gardening, and traveling. So, with a round of applause, let's welcome Reverend Mrs. Olivia. You're welcome.
Good evening once again. I think, please, you have, the screen has a different presentation. Technical, the screen has a different presentation. Thank you very much. I'm Olivia Nyako-Mensah again. I'm presenting on a comparative comparison of classroom, traditional classroom and clinical area versus the virtual classroom teaching and learning in selected hospitals and sites in Ghana. Okay, so we realized that the wave of COVID-19 changed the status quo from the classroom or the traditional classroom where there is a teacher and then there is demonstration in person to that point where we were using the virtual means of interaction. And you realize that at that point, we had no option based on the pressing need of the educational force. So hence, we tried as much as possible to initiate the bit of the virtual classroom teaching and learning, and also made sure that these digital learning tools were available for our students, especially the specialist training personnel. So stakeholders in this Ghanaian specialist training had no option because we wanted to harmonize the style of teaching and learning. And despite the efforts, the experiences and the perspective of these people are overlooked. Hence, the inception of this research work. The aim of this study explored and compared qualitatively the traditional classroom and clinical base to that of the technological enhanced virtual teaching and learning from the perspective of the stakeholders in the Ghanaian specialist education. So our methodology looked at having the approach as qualitative, and then we use the design of exploratory descriptive design. That is our first focus. But on entering into the field, we realized from our pilot study that most of the narratives that were coming from it was much more of an appreciation to what they were doing. So we leveraged and buttressed it up with appreciative inquiry. So it's AI. This time it's not artificial intelligence, but an appreciative inquiry method. So we use, by way of research setting, is a multi-site because we use the 3 traditional sites of Gcnm, which is Kumasi, Accra, and Tamale, and is a multi-leveled research as well, because we use different levels of the hospitals, tertiary, the district, as well as the regional hospitals, where our residents utilize for clinical practicum. And then we also name these sites because of the sensitivity of the research. We named it alphabetically ABCD for anonymity's sake. For our study population and eligibility, all residents at post at that time was used, faculty members that were present and were coming to the sites to teach, to also help with the clinical supervisions were also utilized, as well as the clinical educators and then preceptors. And we also tried using stakeholders such as residents, clinical educators, and then preceptors, like I said. And then we used interviews as our method in our data collection, as well as focus group discussion. Because the college leverages on reflective practice, we also use the reflective journal, the excerpts of the reflective journals, and then we also ensure that residents were all put into focus group discussion. Our data collection process with the sampling method, we started with purposive sampling. Technical, you are going too much. Purposive sampling, and then we continue with consecutive sampling technique. And then our data saturation was not predetermined, it was reached at saturation. Our sample size was 24. And then ethical clearance was sought from Committee of Human Research and Publication Ethics Committee in KNUST, as well as Konfanochi Teaching Hospital. We ensured rigor with confidentiality and anonymity in our data collection. Prior to the data collection tool, we ensured that our data collection tools were validated by experts on the field through panel expert discussion. Then our data collection method, we also utilize the Zoom approach and as a method, our tool to get the information from the participants. And then we used the unstructured interview guide in the form of grantor question to explore what they have for us. Then with the reflective practice, we leveraged on the GIPS framework for our residents to tell us their experiences in having both or finding the differences between the two. Kindly move, please. Our data analysis used the thematic analysis according to Bryan and Clark, hybrid thematic analysis with a 6-step approach. And then we also added the 4 Ds, which is the discovery, dream, design, and destiny of the AI approach that we added on. And then we also use the Envivo version 8 software to analyze our data. And then joint review of codes were also done. Our findings gave us 3 thematic areas. One is the flexibility and accessibility. And then out of that, we have 2 sub-teams which looked at the restrictive versus the flexibility nature of the classroom and that of the virtual class. We also had accessibility to resources as one of our sub-teams. And then we also had limited hands-on experiences, which is a technical hurdle that was given. Then we also saw the need for training and support using digital enhanced learning tools with training needs and support and economics. Please move. Our code for each of them is there. Some were from the residents, others are from faculty members, which was done online. And then each of them was in line with a practical work that has been published in a similar area that gave information that both tradition and then the classroom is good. However, most of the stakeholders were in tune with the virtual classroom because of flexibility. They said it's so flexible to the extent that they can even cook and be doing their classwork as well. From some of the faculty, they said they don't need to travel to get the work done. Usually in their confines as part-timers, they could do it and then have residents also concentrate on what they were doing. So if you read from this very code, it says that traditional labs, for instance, simulation areas, gives hands-on. This was a positive aspect of it. And you realize that the resident was saying that unlike the traditional way, where they have the time to get the simulations done, the online ones do not help them at all because they are not getting the hands-on as expected. And then another one was on a preceptor saying that it's good to have the virtual means because they even do clinical conferences virtually and it is also helping them. And then faculty member also said that after knowing what the virtual means is, it has become a game changer for them as they move. This also is in line with another work done by Kamal et al. 2022 here in Ghana that also looked at the differences between this traditional classroom and the virtual means. And they also said that the hands-on experiences and the technical part of the virtual classroom is challenged. And hence, there is a need for us to do the hybrid teaching and learning. On the last one, the resident also reported that they get support, which is positive, from the Gcnm IT right from the beginning when they are having their orientation. So they are taught about how to go about the use of the virtual means, which is also a good pace for them as they move on. And then faculty members are also saying that support for technical issues is great. I must commend the Gcnm, the college's ICT for the best of support they have given to even faculty members when they are using the virtual classroom. So most of the narratives were much more into the positivity of the virtual means. It's in support with another study by SCI 2022 that also said that the virtual means is good once we get training and support for it. So in conclusion, the study concludes that both traditional and virtual approaches have their own strengths and their weaknesses. However, most of the stakeholders were in line with the virtual means than that of the traditional classroom method. And then they said that some few challenges were identified with them as they utilized the virtual means, which has to be addressed. Internet issues, power fluctuations, economic challenges like buying the bundles and the rest. Stakeholders play a crucial role in facilitating the learning in both settings. and training should be given to them all. They also said that there is a need for support and effective implementation of technological enhanced learning to bring success in our training. Finally, this is our references, and thank you very much for your audience.
Thank you very much, Madam Olivia. They have done very well. Please, can I call all the presenters upstage as we prepare for questions? And I want to know how many of you have questions. Just raise your hand and then we will start giving you numbers and then you prepare to come up. Okay, so I have 1 here, 2. Keep your number in your head, though. I'm a grandmother. Any other question? So we have 2 questions for now. Okay. So when you come up, where's the mic? The other mic. Okay. So please tell us who you are addressing the question to. Please take your seats. And then we'll pass it on to them.
Please, my question is to the last presenter. I want to know, you were talking about stakeholders. Did you involve anybody at the college as a stakeholder? Either a faculty chair, vice rector, rector, director of any of the members of the college? Did you involve any of them as a stakeholder? Thank you.
Are you clear with the question? Olivia, are you clear with the question? The question is to you. Are you clear with it? Yes.
No, I did not involve any of the faculty chairs or any of the vice president and then the president in this study. Rather, because they were situated at the clinical site, and you realize that most of them are not in the classroom. I took ethical clearance from the sites the site approvals from the sites that they were working, and then also took ethical approval from KNUST as well as Confanoche, which is also part of the training sites. Thank you.
Thank you. My name is Frederick Adiak. My question goes to the first presenter, Mr. Opoku. I would want to know for how many semesters is the sign language being taught in the school? That is one. Secondly, were you able to get from the students the impact of this course that is being taught at their clinical site as they go for their clinicals? Because if something must be done, it must be done well. Thank you very much. The second one, were you able to get to know from the students how the impact of the sign language that they learn, how it is being translated at the clinical site anytime they go for clinicals?
All right, thank you. I think with the first question, that course is done 1 semester. And even as it was mentioned, it is non-scoring. It is not added to their grade point. So they may not see it as serious. And that's why they were very happy with the assessment procedures with it. And then the second question has to do with whether they are able to. That's where we also mentioned that they don't have the confidence to be able to use the sign language when they meet the deaf patient. So they don't have that confidence. The impact is not being felt. So as it was recommended that we have to do more practical work with the use of the other assessment tools, or more practice with the use of the video assist and all that, if we really want to implement this sign language and make sure that it make an impact, then we have to put in more effort to make it more effective. But as it is now, and with the study, it is not that impactful. Thank you.
Any more questions? Yes, so you are number 3. But before you come, I have a question for you. The sign language, the deaf people, are they all signing? You see, the students learn how to sign. But when they go to the field, have all those people who are signing so that they can communicate with them? That is one question that has been really bothering me, because they may be there, but if they don't know the sign language themselves, how do the students approach them? Did you meet anything on it that you can tell us about?
Now, with that, the sign language is learned in their schools. So, no. So what I'm saying is that it is done in their schools, and therefore, it is possible that those who have not attended the school don't know the sign language very well. So, I think it is further studies we have to do more if we want to actually implement the sign language in our schools. There are a lot of studies that we have to do.
Because I met somebody who was deaf, but me, I use signs. I didn't know this. I didn't know how to sign. I just did things, and she understood. And we were always communicating. So anytime I go there, they say, "Hey, your friend has come. Well, then we'll be signing." Then later on, I came and heard about this sign language. But this woman didn't know anything, nothing about sign language. And me too, I didn't know anything. Meanwhile, we were communicating. So I think there's something that we need to, we are assuming. It's just like going to a place and saying that, okay, I speak English. So all the people there speak English. So let me speak English with them. If they haven't been to school and they can't speak the language, there's no way you can go about it. So maybe council and college can start looking into that, and let's do more research into it and see how we can help in this country. Yes, the questioner. Where's the mic, please?
It's here.
Oh, there's somebody here before you, so let the person ask the question, then after that you come, please.
Good evening once again, and thank you all for the brilliant presentations. Regarding the sign language, actually we all have issues that we talk about. But the issue is that, in fact, it's not for them to be proficient in sign language, but just the foundation. And so to strengthen the work, what our advice is that in schools, what we do is that, yes, it's not scoring, they will write NMC exams, but it will appear in their transcript. Second, they also write, it's a criteria. If you don't pass, you write the final exams. Now, when they happen, they set up. What other schools also do is that they, after the 4th semester, now when they get to the 5th semester, we send them to their schools for them to interact with them. And here, the issue is that malaria, headache, pain, just those fundamentals, not necessarily too deep. Because I met a scene where a couple, both were dumb and deaf, and the wife was pregnant. They were brought to the hospital. You could not even just understand what they were saying. But so this is just to give them at least the foundation so that they are able to maneuver malaria, pain, so they can take care of them. So maybe you look at it so that further those things can be done. And then also with the virtual learning, I think at a point you said they will have divided attention, I mean doing other things. So maybe, for learning, not all of us, I mean, when you are in classroom teaching, you even have students browsing, sleeping, but you can always check. So I would rather say that possibly if we can combine the two, so that at least we look at the way forward. And then the unmet psychological expectations. I don't know whether respect or sympathy was enough to satisfy the patients, or you explored further. because you talked about sympathy, respect. These were the things that they were satisfied with. Because when you look at a typical African setting, a chronic illness attracts or assumes a spiritual dimension. So sometimes when they come and they are not able to meet their needs, then they begin to look around. So maybe you look at it. Thank you.
Thank you very much. You didn't give us your name and your designation.
My name is Sebil William, the principal, Necessary Trade School.
I knew you were a principal. The way you were going on and on with it. Thank you very much for your contribution. We really appreciate it, don't you? Okay. There was no question. Please give it to the next.
Please, my name is Borhana to Hafiz. My question goes to Mr. Alberto Poku, my former principal. I wanted to know whether the study was done in only one school, and if there is a possibility of other studies to be conducted in maybe regional basis, so that we can get to be able to generalize with the information that we are getting or feedback from the students. Thank you.
Okay, so the study was done using the whole country's nursing schools, and it was divided into two. So we used 8 regions out of the 16 regions, and we used the Solvi formula from the Cochrane's formula. So we estimated with that formula, you have to estimate about 10,000, and out of the 10,000, you use the half of it, and then we had 5,000 of it, and then use it to do the calculation, and then we got the sample size. So it was actually done for all the almost all the schools in the country. Thank you. Yes, it was a countrywide survey that was done. Okay, thank you. And then to add to what my senior colleague said, I think you made a very important suggestions. And that's what I keep on saying, that if you want the sign language to be very effective, then you have to put more effort, do more study on it, and make sure that our students can actually practice it and then apply them at the clinical site. So we need, this study shouldn't end here. We have to do more studies and come out with more recommendations and for it to be implemented. And as we have done, it shouldn't end here. We should pick the recommendations if it's possible and then work on it. Those that are supposed to work on it should do that. Thank you very much.
Any more questions? No more questions. Okay. It's getting to dinner time, so I understand. I have one question for Abigail. If my granddaughter asks me, Grandma, what is south to south? What should I tell her?
Thank you very much for the question. I think that globally, we have the global north and then the global south. So when we talk about the global north, we are mostly referring to high-income countries, and then the global south is like the low and middle-income countries. So when we say a south-south, to say that this is a collaboration between two low and middle-income countries. As you know, most of collaborations are usually north and south, and sometimes we tend to sort of adopt foreign interventions, which are sometimes not really contextualized. And in the spirit of interprofessional collaboration and cross-border collaboration, we felt that we should link up with our partners also from the other low and middle income countries. Thank you.
Thank you very much. I asked that question intentionally because researchers and professionals, we are very fond of assuming that people understand our definitions. But I won't be surprised if somebody is sitting here, she says south to south. What does she mean? But she won't ask, because if she asks, everybody will say, what, don't you know south to south? But it's very important that you come to the level of the lay person when you are explaining things. That's what makes us nurses and midwives unique. If you go to the church and a doctor comes to give a talk and a nurse comes to give a talk, you see the difference, because we are very close to the people, so we come down to their level, to their language. And in the same way, when we are presenting, let us come down to the level of the lay person so that we all understand. Somebody may be here who, I'm not talking about us, but somebody is passing by and then she's listening. Hey, what's this out? Is that what's this saying? And this will be helpful. So thank you very much for the explanation. Now I'm going to give you a minute each for you to give us your closing remarks. People are hungry. I don't know what the president is going to do, tell us about the next section, but just a minute of your closing remark, what you want, your take-home message for us.
Okay, thank you, Madam Chair, and thanks to the Gcnm for this opportunity given to disseminate our research work. I want to reiterate that as a profession, we have to collaborate more to do a lot of research so that we can improve our profession. It's the only way that we can improve the profession to the benefit of our patients. So the members here who have graduated, you should get in touch with people who are good in research and form teams with them and come out with more research and publication. Thank you very much.
Okay, thank you. Also, on behalf of Grace Arthur, I will also say that it's important that we all know about disaster preparedness, which will help us to mitigate the outcome that may be deleterious to people's life, and also encourage leaders to also consider CPDs on disaster preparedness, because it's a teamwork and it goes through 4 phases, and everybody should be armed, so that in case that now that we have climate change and once in a while it rains and then in Ghana there's flood and all that, we should all be alert, whether you are in the south or you are in the north, to know how to prepare for such disasters. Thank you.
Thank you. I'll conclude by saying thank you to Ghana College of Nurses and Midwives for this opportunity, and also to you for your audience. My take-home message is a quote from Benjamin Bala that was captured in the World Health Organization Mental Health Report 2022. It says that if people with psychosocial disabilities receive the attention and services they need, they too can contribute meaningfully to the world. So let this inform our nursing practice, research, education, and policies. Thank you.
Thank you very much. I will say that thank you to GCNM for this opportunity. I would like to alert each and every one of us that when we talk about research and then we come displaying, we come talking about what we have done, and then it doesn't go disseminated, then it means that we have not done our homework well. So I will encourage every one of us that when we conduct the research, we talk about it, it has to be disseminated, it has to be implemented and sustained, so that we can know that we are doing something. At the end of it all, it boils down to us leveraging on the fact that hybrid teaching and learning is the key. Thank you very much.
Okay, I'm very happy to be the last person to speak. And I would like to remind all of us about the universal health coverage and its tenets. And it says that all people living in Ghana, irrespective of their gender, their ethnicity, their location, and what have you, should have access to essential care. And this essential care also includes mental health. And if we look at the pillars, we realize that mental health issues are really not looked at. And even in the realm of mental health, adolescent and teen mothers are also neglected. And I think that we all owe it as a society, because we say that the best
way of assessing a society is the way it treats its vulnerable. And I think that as nurses and midwives, we should be advocates for the voiceless and for the powerless, and we should really take this issue seriously. I always make reference to a friend of mine whom, when we were in school, had a teen child, and all the hassles that she goes. For me, I think that is always a daily reminder that we shouldn't just look on. They say that the world is a dangerous place, not because of those who do evil, but because of those who look on and do nothing about it. There are lots of issues in nursing and midwifery that we can all solve. And the beautiful thing is that these days we have people who have gone ahead of us. We don't always have to reinvent the wheel. If you have an idea, I think it would be good that we collaborate among ourselves, share and see how together we can really build our profession. Because whether we like it or not, this is what we have. And if we, the people who are in it, don't do anything about it, then of course we are leaving things to change. So I charge each and every one of you, and I say that I am a testimony that it is possible. Research used to be a nightmare, but sometimes it amazes me that I can now stand in front of people and talk about it. So let's all get involved and together achieve the sustainable development goals. Thank you.
Thank you very much. Thank you, all of you. Please, let's give them a round of applause. They've done a brilliant job. Thank you, my presenters. You have really done it well. And I'm so impressed at your use of time. Please keep it up wherever you go. And please, let's learn from it. To all of us, like she said, don't let research be a nightmare to you. Please. It's good and it helps us. And I'm really happy with the opportunity that the college is giving to all of us to go into research. We are doing research every day as we are going around, just that we are not documenting it. But now if we take it serious, we can look at some of the topics around us, look into it. We will then be able to work with them and then change our world to make it a better place. Thank you very much and have a good evening.